Hey, welcome to Moving Conversations. Listen, Nora is traveling right now. She's literally playing Planes, Trains, and Automobiles, the live game. So, what I decided to do was take a look back into our archives and just see what might sound interesting. And we've talked a lot about so many different topics, but one that keeps coming up is fascia. And when looking through the archives, I saw that we had a multiple episode shows on fascia and thought, this would be a very interesting thing to revisit. So, over the next couple of weeks, we're going to be bringing you those episodes once again, all about fascia. I hope you learn a lot. I was re-listening to these and reminded myself of a whole lot of information. So hopefully it'll do the same for you. And listen, please subscribe, like, do all those things that you normally would do for any podcast that you enjoy. Give us a 5-star rating if you can on Apple and whatever platform you listen on, Spotify, whatever it is. We really appreciate it. Check out the YouTube channel as well. That way you can see Nora and I doing this live on camera. And as always, you can get us at movingconvos@gmail.com or through Instagram at Moving Convos, Moving Conversations on Facebook. We'll check you out in a couple weeks live. We'll see you soon. Welcome to Moving Conversations, a podcast for movement professionals by movement professionals. If you coach, train, or teach movement, Pilates, or fitness, then this podcast is for you. With more than 60 years of experience in fitness and Pilates, your hosts, Brian Ritchie and Nora St. John, explore the science of human movement, diving deep into the facts, myths, and common misconceptions, hoping to spark thought and conversation about how we view fitness and movement. Now, let's jump into Moving Conversations. And welcome back to Moving Conversations. I'm Brian Ritchie. Joining me as always is Nora St. John. How are you doing this morning, Nora?
Very well, Brian. And yourself?
I'm doing good. Yeah, you gave me a lot to think about in expanding my knowledge of fascia last week. I know we did just tips of the trees last week where we sort of covered some of the basics of fascia. And 99% I knew. There are a couple things that I was like, oh, I hadn't thought of it from that point of view. So I'm really looking into diving a little bit deeper today, getting a little bit more into, more of the fascial slings and thoracolumbar fascia, especially because you and I have both lectured on the topic and I find it fascinating. To me, that is really where, in fitness, I find our focus seems to be in force transmission. So I wanted to dive into that and talk anything else that you were interested in to, go into with fascia. You ready?
Awesome. I'm ready.
Awesome.
Let's get going.
All right. First let's break down the anatomy because that's always sort of the best way to do it. So explain to me what thoracolumbar fascia is, where it lies, what does it do, how many layers, et cetera, et cetera.
Okay. When I talk about this, just to full disclosure here, there are some very detailed, specific understandings of thoracolumbar fascia that are used in the scientific community to explain the anatomy and how force transmission works through it and that kind of thing. I'm going to use some of that, but I'm going to, as I often do with the slings, I'm going to expand some of what I see as the connections into the thoracolumbar fascia, simply to think about it as a movement system, not just as an anatomical system. Okay, just that's my caveat or my full disclosure. So the thoracolumbar fascia, if you've ever seen the picture of a skinless body from the back, you'll see a silver triangle that goes along the sacrum, like it's kind of like a V, a deep V on the sacrum, and then comes up and attaches onto the spine. And you'll see that lovely little like silver triangle typically. That's the outer surface of the thoracolumbar fascia. That is only the outer surface of the thoracolumbar fascia. So let's dive into that, okay?
Now that's,
so on the outs, yeah.
That's interesting because back in pre-med, when I was at the University of Hawaii, we covered all of this, and all that was called was aponeurosa. All that was considered aponeurosa coming down from latissimus dorsi into the lower back. That's all that was ever mentioned about this. So they ignored completely what this was. So that aponeurosa really is just that outermost surface.
Right, and that is, if you think about the aponeurosis or the kind of the semi-tendon, if you will, of the lat. Coming down from the lat, the muscle tissue goes into that aponeurosis. That aponeurosis connects onto the spinous processes and down into the sacrum.
Got it.
Kind of getting that picture?
Yep.
Okay. So that is the superficial layer. Now, a couple things I want to bring up. I want to bring up some names, guys. For those of you who have studied anatomy or looked into fascia a bit, there's a man named Grakovetsky who talks a lot about the thoracolumbar fascia and how it connects and how it informs movement and function. There's also a man named Andrei Vleeming, who works with Diane Lee and talks a lot about the interaction of the thoracolumbar fascia and its role in lumbopelvic stability. All right, so just throwing those names out there, they will come up as we go. So that's our superficial layer, is the aponeurosis of the latissimus dorsi. Now, if you go in just one layer deep to that, you will find, let's start from the center of the spine out, you'll find the erector spinae. Right, if you remember any of your anatomy, you've got your spinalis, your iliocostalis, your longissimus, all of which come down along either the spinous processes, the transverse processes, or the ribs, and they make three chains or bands of muscle that come down the sides of the spine, connecting all the vertebrae together. And then towards the bottom, at various places, depending on what scheme you're looking at, they become fascia, right? The muscle tissue doesn't really go for many of them all the way down to the sacrum. Instead, there's this fascial connection that goes down onto the sacrum, yeah, and into the low lumbar vertebra. So you've got the outer layers, the aponeurosis of the lat. Deep to that is this fascia that is connecting all of the erector spinae. Okay. Then if we go out from there, so that's like those are encased in that's fascia that's encased in fascia. If you go out from there, you have this whole fascial coating around those erector spinae. And at the kind of the corner of that, if you will, you have a fascial connection into the transverse abdominis and also, to some extent, into the internal oblique. Okay, so that creates a whole ring of tension. So the fascia from the transverse abdominis and the internal oblique goes all the way around with the muscles, and then they're coated with fascia, as all muscles are. They connect through into the linea alba in the front of the body. Mm-hmm. So you create basically a ring of tension, or a ring of fiber and a ring of muscle that can create tone in the abdominals. That's basically what happens when you pull your abdominals in. All that stuff is toning up.
Got it.
Okay.
And that
clear? Any questions?
So that wrapping around creates sort of that, it creates a cylinder, basically.
Yes. Yep.
But I noticed that, and we've talked about this before, it does not encase the external oblique, though.
Correct.
Okay, so the external oblique is completely separate from that portion of the unit. It does the transverse abdominis, internal oblique, as well as the rectus abdominis in the anterior section. Does that?
That's sure. That would make sense.
In general.
Yeah, I mean, it's in general, yes, absolutely, because it's going to go. Remember, the transverse abdominis, it comes around to the edge of the rectus abdominis, and then its fascial sheath goes behind the rectus abdominis, mm-hmm. right, to connect to the linea alba. The internal oblique, right, follows those same lines, different fiber angle, but that same basic area of the body. But its fiber, its fascia, when it comes to the rectus abdominis, creates a sandwich. So some goes behind the rectus abdominis, some goes in front of the rectus abdominis.
Okay. All right.
So the internal oblique actually, like its fibers, its aponeurosis, literally sandwich the rectus abdominis.
Okay. That makes sense. Makes sense. So it creates that cylinder anterior to posterior. But the thoracolumbar fascia, as we mentioned earlier with the latissimus dorsi, it also goes superior, inferior, and also at angles.
Right. So I'm going to expand this just a bit. So we've got our superficial layer is our lat, right? Our lat aponeurosis. We've got this, sometimes called the middle layer of the thoracolumbar fascia, which is on the inside of the erector spinae bundle. Okay, so it's going to go from the transverse process out around that erector spinae bundle. Mm-hmm. Sort of makes sense. Then there's the quadratus lumborum, which is sitting just interior or anterior to the erector spinae, right? It goes along the transverse processes between the 12th rib and the top of the iliac crest.
Mm-hmm.
Okay, so that's another bundle. So then that's also coated in fascia. That's surrounded by a fascial layer. And those three layers, so the layer on the front of the quadratus lumborum, right? So the front of the body, the layer between the quadratus lumborum and the erector spinae, and the posterior layer all come together to merge to form this little triangular area, this little area where all those fascia come together. And that's where the fascia of the internal oblique and the transverse abdominis connect.
So visually, it's almost like a club sandwich or a Big Mac, where you're having the three layers of bread would be your fascia, whereas the meat in between would be, the musculature.
Your muscles.
Okay.
Right. Exactly. You just pinched the outsides of your buns. You pinched your buns together.
You made a panini. You made a panini with the ends, and it came together. There you go.
Right. So that is how they usually talk about the thoracolumbar fascia. And so, guys, take a moment if you can. I know that was a lot to just throw at you. That little moment where all three of those layers come together is called the lateral raphe. Just so you know, that's that term where all those come together, and that's kind of where the magic happens with our core work. So it's that engagement of the transverse abdominis, sometimes the internal oblique. There's a lot of, I was thinking about those as having different actions, but they're so close together. Mm-hmm. They have to work together in some ways, right? So that tensioning is what tensions the entire fascial structure around the lumbar fascia, around the whole lumbar vertebra. And that helps to create axial elongation and decompression of the lumbar spine and stabilize the lumbar spine in movement.
You said
so
something
that's how we think about the inner unit.
Yeah, you said something very interesting about the internal oblique working with the transverse abdominis. Anybody who's ever done any dissection work, and you've done a lot, there's not a whole lot of separation between a lot of these layers. A lot of them sort of merge or smurge with each other, that they're not as clean and crisp and clear cut as you see, in a lot of these, anatomy books as we grew up with, or apps, which most people now are learning on, where you can peel away one layer. Well, it's great to be able to do that on a computer, but in real life, how hard is it to peel away a single layer? They're right up against each other and sort of connected, fascially and attached.
And they're millimeters thick. They're not honking muscles. They're little skinny sheets of muscles. The other thing too is, it's always a habit, and I think it really helped us understand anatomy originally to break things down, right? To look at just a transverse or just the internal oblique or just this or just that. But in reality, whatever you're doing, if you're sitting there and watching something or reading something or rotating slightly, they're working together. Okay, they're not working independently. Mm-hmm. The external oblique doesn't work independently either. If I'm moving my torso in any direction, all of those muscles are going to be working to do that job.
Yeah.
Right, and they have to coordinate and act together and glide appropriately because their fiber angles are different.
Yep.
Okay. So coming back to the back of the thoracolumbar fascia for a moment. Now, if I take this up, I'm thinking about this at about most of the images of this are at the third lumbar vertebra, which is where you still have a lot of the fiber tissue from the erector spinae. As you get lower, you might lose some of the fibrous tissue, the muscular tissue. But here you actually have the muscular tissue of the erector spinae at that point. One thing that I often think of, and this is just my extension of my understanding of the thoracolumbar fascia, this isn't technically part of the thoracolumbar fascia, is the psoas major. Mm-hmm. The psoas major is right up inside the body, right against the bodies of the vertebra in front of the transverse processes, and right next to, therefore, the quadratus lumborum.
Right.
All right. And if you think about any action of the lower body, think about a lateral flexion. All right. If I laterally flex, like I'm side bending over to my right, I'm shortening my quadratus lumborum on my right side. I'm actually shortening my psoas major on my right side. I'm shortening my erector spinae on my right side. Yep. I'm actually shortening my lat on my right side. Right, all of that is coming together.
Yep.
And all of it is working together to create that lateral flexion, for example.
Right. Right.
Yeah.
The pivot point
So
of the
that's
spine would
yeah.
really be those transverse abdominis, because everything posterior to the transverse abdominis puts you into a slight extension. Anything anterior is
Yes.
going to put you into flexion. But if you talk
Exactly.
about lateral flexion or even some rotation, both are working.
Yes, exactly. Exactly. So a bunch of things we talked about last time in terms of fascia that come up to play here. One is glide. That all these tissues, yes, these may be working together, but they may be working at slightly different angles and slightly different amounts of contraction or angles or directions or vectors, right? So they have to be able to glide somewhat, have some relative independence so they can do their job and not do somebody else's job, right? So that's just one thing to think about is looking at glide in that area. So if you've had an injury, if you've had a low back injury, if you've had surgery, all of that can get disrupted. So just pointing that out. The second thing that I want to mention, and this came a lot out of doing some dissection, again, some unfixed cadaver dissection, meaning the cadavers were not preserved with formalin and other kinds of things. When you dissect the back of the body and you can look at the thoracolumbar fascia without the skin, and you can really see the fiber angles within the thoracolumbar fascia when you do that. And what's really interesting and fascinating, both in the back of the body and also in the front of the body, looking at when you've taken off the front chest wall and looking at the external oblique, for example, is the two sides can look very different. So if I'm looking at the thoracolumbar fascia from the back, you would think that the fiber angles would be symmetrical around the spine, right? They'd be like diagonally coming down from my lat in the same direction. But there's usually 2 or 3 different layers of fascia, which are going at depending who you talk to, about a 70-degree angle to each other, which is interesting. And this is a deep fascia that has multiple layers to it. Just threw that out there. Take a moment. But basically, those can build in different ways depending on how the body is used. So one thing I didn't talk about last time was that we build our fascial suit.
Yep.
So our fascia, again, molds to how it is used. And so whatever we do habitually is what creates our fascia. And if we want to change our fascial structure, it often takes, again, 6 to 24 months for those fascia to actually restructure and reorient in the direction that we want them to reorient into.
Yeah, athletes who are one-sided especially.
Yep.
What just popped into my head, I worked briefly with she was amateur level bodybuilder, but high level amateur bodybuilder. And what was interesting is in her training, one of her traps, her right side, was so much larger than her left. And it was visible because, when you strip down and have almost no body fat, it's very visible. Under normal circumstances, you wouldn't see it as much. And we couldn't figure out she's lifting the same amount of weight on each side, And then one day I watched her train her triceps, and where she had her favorite machine was the mirror was always to the right. So every time she did it, she was watching herself with her head turned to the right. And I watched her whole workout on that machine, and almost the entire time her head was cocked to the right. And doing that for years and years and years created an imbalance muscularly that was fascinating from my point of view anatomically. I was just thinking, wow, just having her head turn that way while training changed how that was pulled. And you could see that when you're creating your fascial suit, if you do create those habits, and like we've talked about baseball pitchers, we've talked about people who are throwers. I could just imagine shot putters and javelin throwers and all of these type of people who are just naturally all one-sided in that sense, that their fascial suit is going to be completely different than, let's say, a marathon runner who is pretty much sagittal and pretty equal on both sides.
Yeah, absolutely. Absolutely. I mean, you just see it in the muscle development. You just see again, I worked with a couple of serious pitchers and a throwing athlete, and their right side, they were both right-sided. I mean, every muscle on their right side was inches bigger than on their left.
Yeah.
Their calf was 1.5 inches bigger. Their thigh was 2 inches bigger.
Wow.
Their right arm was 2 inches bigger. Their right bicep was 2 inches bigger.
Wow.
The upper arm.
That's significant.
Than the left.
That is hugely significant.
And this was years after they'd stopped the sport. This was 20 years after they were done with their training.
Mm-hmm.
I mean, obviously they trained, their entire youth and built their body that way, but all that remained even after that much time.
We see it with carpenters and mechanics, auto mechanics, using those who used a screwdriver for so many years or a hammer, that their dominant hand and arm, their forearm, can be significantly long or stronger and circumference-wise much bigger than the opposite side.
Yep.
Yeah. Interesting.
Yeah. So you'll see that directly in the thoracolumbar fascia. And one of the things that, we talk about a lot, certainly in Pilates and certainly in fitness, is when you think about core training, a lot of what we're trying to do is, I think, balance the forces on the spine, right? Trying to have not asymmetrical forces going through the spine, because that can lead to disturbances and injuries and that kind of thing. But boy, when you see the fascia and you see the asymmetries of it, you realize that is a challenging thing to actually do. That we're just not symmetrical movers for the most part, even if you do symmetrical activities and you're not a very one-handed athlete. We are still generally asymmetrical, have rotational patterns and other kinds of things that just live in our system and live in our fascial system.
Yeah, even if you're not athletic, you can see it we see it all the time in muscular imbalances with clients.
Yeah.
I can tell someone what side they carry their purse on, or they've carried a backpack on, or how they sit at their desk, where their computer monitor is. And it's almost like Karnak, I'm delving in, and they're like, how'd you know? It's like, well, you can kind of see your body's rotated significantly to the left, and your head is turned to the left almost all the time. You can see those, those muscular imbalances created with almost no resistance. We're not talking about
just habit,
just habitual.
No, you're talking low. You're talking just habit.
Yep.
Habit and practice. As one of my teachers, Eric Franklin, always says, practice doesn't make perfect. Practice makes permanent.
Yeah.
Right. Whatever we do is what our body learns to do. So, it's not that it necessarily makes it better. It could make it better, certainly, but it also just reinforces whatever that pattern is.
Absolutely.
So getting back to thoracolumbar fascia, I want to expand this a bit. And so we've talked through the back pretty much to the iliac crest and to the sacrum. But if you look at the back of that body, you'll see that diamond, where it goes along the iliac crest and along the edge of the sacrum, there's another fascia that connects right into there, which is the fascia that goes over the glutes, particularly gluteus maximus. And so you see that connection, that diagonal connection from the lat across the body to the opposite hip, which is what you need for rotation, right?
Yeah.
That's a classic, like if you talk about walking, you talk about running, you talk about a normal human mobility factor, mobility exercise, movement, you're going to get that diagonal connection from the upper body down through the lower body. And one of the things that I always like to think about when I'm thinking about the thoracolumbar fascia is not just its action on the back, but where it connects the upper body to the middle of the body, to the hips, to the lower body. Because in movement, that's what we're always trying to do, is make that integration and make that coordination between the different body parts as smooth and optimum as possible, right? Smooth and fluid as possible.
Interesting. In my research and things that I was focused in on, working with various companies and consulting with creation of exercises and things, was to do things in a standing fashion, to load the core while standing. And everything that was coming up really shows that your core is tied into your feet so much through this thoracolumbar fascia, because anything that I did in a standing position, pushing forward, pulling, had to come from my feet. My power was really generated through the ground force. If I wanted to have any power at all, had to come through my feet, through my hips, up through my torso, and transfer up to my upper body before I could even do my pressing, my pulling, my twisting with my upper extremity.
Force transfer.
Exactly.
Right? We've talked about it a bit in various different ways. but the fascia is a lot of what does that.
Yeah.
Yes, there's the muscles that change the force and all that kind of stuff, but a lot of it is the tensioning and the release of tensioning of the fascia, and also the fascia is what coordinates a lot of that.
Yep.
But the fascia, again, is named because as scientists we tend to break things up to figure them out. Right, fascia is named like here's the thoracolumbar fascia, and here's the lat fascia, and here's the this fascia, and here's the gluteal fascia, like all these different names. But in reality, all of these are deeply, deeply connected and intertwined. And it is the fascia that helps to coordinate and transfer that force from the glutes up across the thoracolumbar fascia to the opposite lat, to be able to let that arm either rotate forward or rotate back, right? To let the whole torso like wind up and throw. That comes through that entire X without the body making the distinction, at least ideally.
Mm-hmm.
Right. I've worked with clients where the body have made that distinction and they're not very effective if they're throwing or they're pitching or they're golf or whatever else they're trying to do because they've broken it up.
Right.
But when that body's working well, all of that is fluidly working together as one unit. And that's a lot of where the fascia, what we're trying to design the fascia to do is to work in that coordinated fashion.
Mm-hmm. Yeah. It's very interesting to see someone who has sort of that hitch in their giddy up, who has a break in their motion or their movement. And it is, you can see it. It's very distinct. So it's always, interesting when they don't have that smoothness. Now, one thing I wanted to ask you was to talk about, do we have a system anteriorly that would, I don't even want to use the word replicate because the thickness and the dominance of the thoracolumbar fascia is in a league of its own. But is there a portion on the anterior? This is something that I've thought a lot about because I've had a lot of people with injuries there. Before we get there, I just want to remind you that you're listening to Moving Conversations. Nora St. John and Brian Ritchie. Do us a favor. If you like the podcast, please subscribe. You'll get the latest episode every Tuesday in your inbox. As soon as it's published, do us a favor. If you like the show, give us a 5-star rating. It'll help with all of our algorithms and get us in front of more people. So thank you very much. Email is movingcombos@gmail.com. Instagram, Facebook, Twitter, all of those are at Moving Combos. All right. So getting back to this, is there an anterior, what I've referred to as a pubic sheath before, is there sort of that anterior portion that, does that force transfer in the front of the body that is the same as the posterior?
Well, let's take this around. We've talked about the back, we've talked about the lat and the transverse abdominis and the internal oblique. But let's go through and talk about the front of the body. And if you want to think about, I'm not going to think about just fascially, but just the structure of the front of the body, particularly the front of the abdomen.
Mm-hmm.
All right. So we've got our transverse abdominis as our deepest layer. And those fibers are really purely horizontal. All they really do is contract, pull the belly button in and relax the belly button. That's about all they can do because our fibers don't go in any other angle. They can't bring our ribs towards our pelvis or do a curl or do a side bend or much else. They just pull that in. And remember there too that we've got our central column, our rectus abdominis, going from our 5th rib all the way down to our pubic bone. Okay, so you think about that like, you can think about that, I'm using a funky metaphor here, but almost like the spine or the erector spinae.
Okay.
Not at all the same in terms of structure, but it is a vertical structure in the body, going from the rib cage to the pubic bone. Okay, just thinking about it that way very simply as a structural member that is vertical. All right, so you've got that structural member that's vertical. Then you've got the transverse abdominis that's horizontal.
Mm-hmm.
Okay. So you've got vertical, you've got horizontal, but we don't move just in those ways. We don't just move in flexion and extension. So we also need to have other layers that can help us to move in all the many ways that our torso needs to move for ordinary functional movement, which is primarily rotation.
Yeah.
Right. So then we've got our internal oblique, right, coming down from, I think of these as being mountain fibers going from our iliac crest up towards our midline, and even from the back of the body, our iliac crest in the back up towards our ribs, right? So it's going to come up at that angle. And we've got our external oblique. And remember, the external oblique does not attach to the thoracolumbar fascia. And the reason is this. The fiber angles that the external oblique attaches to the ribs, right, to the front of the rib cage, all pretty much from 5th rib all the way down to 12th rib, but those fibers go forward.
Mm-hmm.
Okay, so they attach that bottom rib, but they don't go back towards the thoracolumbar fascia. The fibers go forward towards the midline.
Mm.
Right, so those fibers are not going to connect into that thoracolumbar fascia because the thoracolumbar fascia is going in the other direction. It would be behind them.
Okay, that makes a lot more sense. It's never been explained to me
that?
why that one sort of opted out of the thoracolumbar fascia, because anytime you see the body, we see it sort of cut apart, sort of transversed at that L3. And you can see where the fascia is, and it surrounds, the rectus abdominis, and it surrounds, it ties into the internal oblique and the transverse abdominis, but it doesn't do it to the external oblique, and no one's ever explained why, but that makes a lot of sense because it is anterior and it is coming across the body toward the midline from the ribs and doesn't have anything really to do with the posterior.
Right, it doesn't go to the spine.
That makes a lot of sense.
Right, I mean it's very close to it, and the fibers are right over the internal oblique. It's not like it's a long way from it; they're right next to each other. But those fibers are not going back towards that to tie into the thoracolumbar fascia. They're going forward to tie into the linea alba in the front.
Makes a lot of sense. Makes a lot of sense.
Right. Now, one other weird thing here. So let's take that. So you've got the front and the back. You've got this X going in the front of the body, like you have an X in the back of the body.
Mm-hmm.
Right, the internal oblique. So going from external oblique on one side, the internal oblique on the opposite, and those two X's, allowing rotation, allowing lateral flexion. What do those tie into? Those tie into the inguinal ligament. Those tie into the iliac, the ASIS area, the front part of the iliac crest. And they come down onto the pubic bone.
Mm-hmm.
So the pubic bone is very close to the inside of our pelvic floor, right?
Mm-hmm. Absolutely.
And our adductors, which are along both the top of the pubic bone, right, the superior pubic ramus, and then also the inferior pubic ramus, right? Those are areas where that sheath of the rectus comes down, attaches onto there, and connects fascially to both the pelvic floor on the inside of the pubic bone and into the adductors on the outside of the pubic bone.
So when you were talking before about the lat coming across the posterior section and tying into the glute, this is doing the exact opposite, going from the external oblique across the linea alba to the internal oblique, but then all the way down into the adductor on the opposite side.
Right. So you have an X on the back and you have an X on the front, and those work in harmony, ideally, to create a rotation, or in a very simple way, to create walking.
Mm-hmm.
Right? A lot of our rotational patterns as humans were created because we walk. That's how we move through space. Many other creatures do not use rotation the same way when they walk.
Right.
Think about a dog or a cat. They're not rotating their torso to walk so much.
Yep.
Right? They're moving their limbs in flexion and extension more as they're walking motion. Think about a lizard, it's using lateral flexion.
Yep.
Right? Or a snake, right? They use lateral flexion to motivate. Humans stood up and decided rotation was the way to go.
Yep.
And apparently it is pretty efficient, actually.
Well,
right? So that's where we need that.
Yeah, and if you look at primates, unless they stand perfectly upright, they never go into hyperextension with their hip. They're usually stuck in a flexed position. They rarely go into hyperextension there unilaterally.
Yeah.
You see gorillas and things like that. If they are, coming at you fast, they're still going to be almost bilaterally extending into slight hyperextension, or they're still going to be only going into a neutral state. They're not going to go posterior to the body the way we do.
With their hips.
Right, with their hips.
Yeah. And they also don't, they don't really walk like us.
No, and they don't swing their arms, sort of to counterbalance that hip going into hyperextension either. So they don't have that rotation. They're stuck in that forward flexed posture. And if you look at a dog, you look at a cat, they never do it either. They don't go into hyperextension in the hips.
No, I'm sorry. You've got me stuck on primates now. I spend a lot of time watching primates move because it fascinates me because they are so close to what we do. So they can sometimes walk a bit like humans, but still in that flexed posture. But I'm thinking about brachiation and going through trees and how they climb. And they really do use every possible plane
Sure.
to do
Absolutely.
that.
No, absolutely. The monkeys especially are doing a lot more rotation in that sense.
Yes. Yeah. And they're closing different chains, right?
Exactly.
Because they're like holding onto one arm and swinging to the other arm and swinging to the other arm. So it's just a very different way of doing rotational movements. But again, humans just took a different path. We stood all the way upright and changed everything.
And stayed on the ground.
And stayed on the ground, that's right. And stopped using our hands in quite the same way.
Exactly.
Use it for a lot of other things, but we don't climb through trees so much.
Yeah, exactly.
Yeah.
Exactly.
So that connection, right? That connection of the front and the back from the upper body, because, remember the external oblique, this is my own version of connecting things, guys. This is not anybody else talks about too much. But the external oblique interdigitates with the serratus anterior.
I wanted to get into that.
Which connects to the scapula. So it takes the scapula which is the shoulder girdle, right? And connects it into the torso, creating that connection from the scapula across the external oblique, opposite internal oblique, down into pelvic floor and the adductors on that opposite side. Right? That's one of the slings I like to talk about. And you think about that very powerful rotational action, and that's balanced in the back. So connecting arm, torso, pelvis, leg with the back with our lat, which it connects to our arm, our torso, our pelvis, and our leg in the back.
And these are basically
looking at that coordination.
Yeah, these are the anterior and posterior oblique slings that
from Diane Lee.
That we
and interglimming.
Yeah, that we've talked about, and taught for so many years. Really, they are the ones that are balancing us when we do any rotational movement, when we walk, when we throw, when we do anything that involves rotation. And they need to be balanced front to back.
Ideally.
Ideally.
They usually are. Usually people are either dominant in the posterior, they're dominant in the anterior, they're dominant on the right, they're dominant on the left. Right? This is really where you see so many imbalances that very, very often can be at least an underlying factor in an injury or arthritis or wear and tear or poor performance, right?
Absolutely. Well, how many times have we worked with a client and had them rotate, doing something like telescope arms, book openers, lying on their side, taking one arm across the body and really trying to lay that shoulder on the ground and really doing a twisting motion. And one side is easy. No problem. They can go so far. And on the other side, they're sort of stuck. They sort of, they get to a point where they can't rotate as well. And we do see that. We see that we have those habits, those habitual motions. If you sit a lot, my psychologists especially, they sit with one leg crossed and they're writing on their lap. So their whole body is in a flexed position, rotated toward the leg that's crossed over, shortening one of their, anterior oblique slings for hours and hours every day.
Yep.
And then try and get them to stand upright and not have that rotation be permanent when you're talking about a 20 or 30-year career by the time they get to us. That's almost impossible. So we have to work to try and erase some of that and try and, strengthen it in a different way that we can almost reverse what they've done for the past 20 or 30 years.
I think of it as postural cross training.
Yeah.
Right? Because, it's simplistic, but it is certainly the training principle I use a lot. If they rotate to the right, I'm going to have them rotate to the left.
Yep.
Right. And I'm going to have them do that. One of the things I was working with the advancement principles is all the different places rotation can come from and trying to identify where that limitation is. Right. So looking at if somebody's lying down on their back and they're rotating their hips, right? They're doing knee drops to each side, for example. You're looking at rotation, not so much in the upper body, but more from the hips. And I do mean the hips. I mean, not just the pelvis, but the hips, like internal, external rotation of the femurs a bit. The pelvis, the low back, right? Like which one of those which way do they rotate better in that lower part of the body? Sometimes somebody will, I'm getting a little specific here, but sometimes somebody will knee drop to the right. Okay, knee dropping to the right, and my left leg will not stay in contact with my right leg.
Right.
okay, because that's a little bit tighter in terms of that rotational pattern, that hip basically on that top side. And that may be causing some of my rotational imbalance. I go to the other side and the legs can stay together as they both drop down to the mat.
That's an interesting concept, because I don't know if I've ever put that together before, internal and external rotation. Now, obviously, external rotation of the hips makes sense. The glutes do that. Piriformis does that. So that would make sense. But as much with internal rotation, would internal rotation be more of the anterior oblique sling then, whereas the opposite is the posterior oblique sling?
Yeah.
Okay. I just it makes sense now that I'm thinking about it, but it's nothing that I put two and two together before in that way. Mm-hmm. But that makes a lot of sense, because almost every person I know lacks hip internal rotation. That seems to be a sticking point for a lot of people. Unless they train it specifically, it's usually a challenge, especially for my men. You know, my golfers and things like that, they really lack that hip internal rotation. It's something we have to work on. But I had never put it in the same, thought process as that crossing over of the anterior oblique sling. Interesting. Mm-hmm. Thinking of limitations, I wanted to bring something else up. We briefly talked about this last week, and that's healing, scarring, surgeries.
Right.
When I first started learning about fascia, and this is 15 years ago, 20 years ago, or something like that, I was told that anybody who's had anything like a liposuction, or especially cosmetic surgery anterior on the body, or liposculpture was really big for a while, where they literally scraped away almost all of the fat and just sewed you back up. And they said that will cause a huge disruption within the anterior oblique sling and possibly the posterior oblique sling, because of how everything wraps around into the transverse abdominis. I've had a number of abdominal surgeries in my life, so I've got, scars that are about an inch or so. I've got 9 of them. And so, I know that I've got these pieces of scarring that are sort of there, that are just, going to be. And I haven't noticed them limiting my ranges of motion and things from just looking from within. But I'm curious if people who have had, C-sections, especially, and whatnot, how that's going to affect that anterior oblique sling, and how that's going to affect the whole fascial system. And can that be reversed so that they can get normal movement back, or normal timing back of that fascial system?
So,
I know I throw a lot at you. Sorry, I threw a lot at you with one question.
No, there's a lot there, and there's actually a lot of really good work that can be done there. So any abdominal surgery, whether it's, now I'm going to talk to a couple different things. There are many ways that they do C-sections, right? Mm-hmm. Sometimes they'll just go straight to the linea alba, right? Yep. And they'll just kind of just open that up. Sometimes they'll actually, in the old days, used to cut right on top of the pubic bone, sort of the bikini line cut, which basically cuts through all the rectus abdominis.
Still do that one.
Connected there, right? If you've got something like an appendix scar, right, on one side, or a gallbladder scar on one side. Now, a couple things. They have generally decreased the size of those incisions with microsurgeries and laparoscopies and that kind of thing. So that has helped some, right? You don't have these giant C-sections you still do, because you got to get the baby's head out, and it's not a small thing to get out of there.
It's a big scar.
It's got a big old scar. So, so several things. One, scarring is a fascial remodeling, right? Fundamentally. Mm-hmm. So you cut something, and basically what happens is the body goes, there's a breach in the fabric, right? There's a hole in my body. And the body's entire desire is to close that hole up as soon as possible. And it does that by going to the area. A whole bunch of immune cells go into there, and they throw a whole bunch of collagen and other fascial tissues in that area to try to close it up, right? And I always think of that as like felt. And if you know what felt is a fiber that is very chaotic, right? It's not like a shirt where you've got fibers going in this direction and fibers going in this direction. Instead, fibers going in every direction. right? And that's really how any kind of wound, whether it's a tiny little cut on your hand or it's an incision in your abdomen, is healed. By all this fibers going in there and just trying to close that space up, close that gap up any way they can.
Mm-hmm.
So what that says to me, and what I know from reading about it a lot, is that means that you have fibers in an area that are not necessarily moving in the direction of force.
Mm-hmm.
Okay, so you've got fiber angles, right? Originally, those fibers, let's say I'm talking the top of the pubic bone, that cut, those fibers would be going pretty much vertically between the fascia of the rectus abdominis and the pubic bone, pretty much straight up and down. And they'd be in an organized way to allow flexion and extension and whatever other mobility is necessary, but primarily flexion and extension at that point, right? So instead now you have these fibers that are going to, instead of lining up in the direction of pull, they're not lining up. They're just a big chaotic mess. So when force goes through there, let's say I'm going into a back extension and I'm trying to stretch out that area, right? Instead of that force moving smoothly from the rectus abdominis fascia right onto my pubic bone and then down wherever it's going to go from there, it gets stuck a bit. It doesn't transfer smoothly from the rectus abdominis onto the pubic bone.
Mm-hmm.
Make sense, right? And so a lot of times what happens with scarring like that is two things. One, you get a discontinuity in the movement between those two areas. It's like it breaks the communication pattern of the fascia from one point to the next.
Mm-hmm.
It's like the relay racer dropped the baton. So it just means those movements get discoordinated.
Mm-hmm.
Right? And you'll see that a lot in people, especially who have fairly major, I've worked with a few kinds of cancer and things that had pretty major abdominal scarring. And it was like you could see that their pattern was just not coordinated in rotation and flexion and extension. Just like had a very jerky quality to it because that force was not transferring smoothly and that coordination wasn't happening from one fascial structure to the next.
Would we see this same issue? I've got a number of clients, male clients especially, but a couple of female clients who have had hernia surgeries where they don't go in and just sew it up. They're now putting a metal plate, almost a mesh there.
Yeah.
And that mesh creates a huge, I mean, you can see one side to the other that they are not able to move like they once were. It like glues them down.
Absolutely. If the fascia is flexible, scar tissue is not flexible fundamentally.
And that mesh is not flexible.
And that mesh, it's designed not to be flexible, right? That's the whole point, is they're trying to have it not stretch and open up and create a hernia. One example that I used of this is I had one of my clients had breast cancer and she had reconstruction. And the reconstruction they did was to take it's called a transflap. So they basically take part of the rectus abdominis, move it up under the skin, and make a breast out of it. So it's essentially the tissue still has innervation and blood supply, and is still kind of living tissue. They did this with a lat. They did this with different things, but that was her particular version. And to do that, they essentially took off or dissected the entire abdominal wall from the muscle underneath it, because they had to go in and take some of that muscle and move it up underneath the skin, basically, to the breast.
So we're talking just the rectus abdominis. They're removing it from
part of it,
the internal oblique and just pulling. Wow, that's interesting.
Yeah. And they did it with part of the lat. They did it lots of different ways. But basically what happened was, and I was there for the surgery, I happened to sit in on the surgery, is you could see then that the entire abdominal wall connection to the muscles underneath was disrupted.
Huh.
And this was a client who was a bit kyphotic anyway. Within 6 months, her kyphosis had increased dramatically.
I can see that.
And it was because the entire abdominal wall had scarred up to the muscles underneath it. And there was no longer the glide. Like you think about it, if any of you just go into a gentle back extension, and you feel how much your skin has to glide on those tissues to make that happen. Right? So you think about liposuction is classic that way. That breaks up all of that connective tissue between the skin and the muscles underneath.
Yeah, I've had a couple clients who have had liposuction that are, let's just say, aggressive liposuction, where they've taken out probably too much and caused a huge disruption.
Yeah.
Huge. And every one of them wishes they'd never had it because they no longer walk the same. They no longer move the same. It's kind of like when you see someone who's had a facelift of some sort, and they don't look normal anymore. They look
they just look odd.
A little odd.
Yeah.
It's not that they don't look human, obviously, or whatnot, but you're looking at them thinking, something's just not quite right about the balance of everything. And I was watching that with her movement, or a couple of them. Just they weren't able, and back extension was so difficult because everything was basically as though they pulled it down and said, I got this. And like a zipper, a zipper crossways instead of up and down. And suddenly they couldn't go back. They couldn't go into a back extension.
I mean, if any of you are wearing stretchy clothes right now, right, whether you've got workout clothes on or a knitted sweater or something, right, it's stretchy, right? So just play with it for a moment, like stretch it. And it stretches in different angles. Like if you've got like workout clothes on, right, they're pretty stretchy. Now take it and pull it, like make a little ball out of it, like hold it so it doesn't stretch, and then pull on one side of it.
Yeah.
And you'll see that the force doesn't transfer now through that little tight ball, right? Like you got pull on one side and then it just stops instead of pulling all the way through. That's what a scar does.
And that's scar tissue.
Now, that's scar tissue, right? And again, it can be a small bit or it can be a larger bit, but that's what scar tissue does. Is it stops that transmission across that fascial line. Now, you can, with fairly aggressive manual therapy, this cannot be done, generally cannot be done with rollers or balls or on yourself. This is where structural integration and Rolfing are your baby.
Yep.
Because generally what has to happen there is you have to work on a combination of breaking down that scar tissue manually, typically, and then working the area. So what I like to do is I like to do at least one session a week, if not 2 sessions a week. And it doesn't have to be long, just to specifically break through some of those cross fibers that are going in the direction you don't want them to go in. Okay, if you think about that, right, if you got felt, you're trying to basically break up all the fibers that are going right that need to go straight and basically break up those fibers so you've got a little more mobility in those tissues, and then work those fibers so that you're trying to get the fascial information saying go in this direction, build the fibers in the direction of pull.
Now, out of curiosity,
so to re-educate that.
Little inside baseball here. You and I are both body workers. I have not done extensive scar tissue work. You have. Can you literally feel where those lines of pull are at the time so you can disrupt only one direction but not the others?
Absolutely.
Okay. Interesting.
Yeah. And, I mean, to some extent, yes, you absolutely can. I mean, some of it is just like if I'm doing scar work, trying to describe this, I can usually show this, but I'm trying to describe this. So, for example, I have a little scar on the back of my hand that was a cut, like a cut straight across my wrist. Okay, so a little cut straight across the wrist that happened a long time ago. And as that was healing, I would take the skin and I would roll the skin. Okay, so I'd pick the skin up off the tissues underneath it. And in the initial phases of healing, now, scar tissue, they say, takes roughly 18 months to fully complete its process. So there's a lot of opportunity in that initial phase to change things. But you've got to take advantage of that initial phase, in my experience. So in that case, like you take 6 to 8 weeks to allow those tissues to knit, because you don't want to be breaking up the tissues that they need to knit. Then you basically the person who's doing the massage will do it in the direction that they want the fibers to work in. So they'll cross fiber against it, trying to break up the tissues that they don't want to have. So they'll do like a little cross fiber on there, and then they will work the tissues in the direction that they want the fibers to grow in. And they'll also, I find that movement is the best way to get the fibers going in the proper direction. So then it's using exercises that stimulate the fibers to grow in that appropriate direction.
Now, there are a few areas in the body after surgery, and I'm thinking Achilles tendon rupture, for instance, or a patella tendon rupture, where you want scar tissue. You want to have that really thickened in order for protection. So there are a few areas where you'd want that, but in general, like in the abdominal region after, a C-section or something like that, or after breast surgery or something of that nature, where some aggressive body work would actually be warranted.
Right. So there it's like making sure that the healing is done to the point where the tissues have integrity, right? You don't want to be tearing open an incision. That's never a good idea. But once that incision is closed, fully closed, and that for me, I've done that at like the 6 to 8 week mark. I'll start doing some massage in that area. I did that with some hamstring tears and some Achilles issues, because I don't want those cross fibers to get embedded, and they'll grow fast and aggressively. So I'll typically say, like, do a couple sessions a week for the first, let's say, go 6 to 8 weeks, let it get knitted, then take another 6 weeks, go twice a week just to try to work through some of that. And both movement and manual therapy together are really the thing that I found has been really helpful on that.
Nice. Very cool. Well, I think that this is a good place for us to pause. And the reason I say that is next time we're going to dive into training the fascial system. So we're going to talk a little bit more about the different, slings that we spoke on today and how we want to load them. Do a little bit of a repeat on a few things like elastic recoil and whatnot, which we talked about last episode. So bringing those things in and basically what we can do as fitness professionals to enhance our fascial system, to train it in the proper way, and maybe reverse some of those, ineffective and problematic for some muscular imbalances.
Oh boy. And guys, just to remind you, this is all being researched as we speak.
Yes.
So we're going to talk about a bunch of stuff. We're going to give you a bunch of ideas. And know that all of them are still undergoing a lot of work to really identify the details of how we can really best train fascia.
I remember when we were at the fascia conference, how someone brought up a brand new study that totally refuted books that were written on fascial fitness. And one of the authors was sitting there who introduced this gentleman and stood up and said, well, I guess you could throw my book away, huh? And it was a very light, humorous moment. And then he reiterated later and said, look, we're still learning. And it's not that what we knew before is suddenly thrown out. It might have to be modified. And there's a lot more research to be done. So again, with that caveat, we're going to be talking about what we do know as of today. And 5 years down the road from now, things may be different.
Absolutely. Thanks, Brian.
All right. Thank you so much. Thank you guys for joining us on Moving Conversations. Hopefully this whole thoughts of fascia are going to, give you a little bit of a, what do we call it? The mind bomb, thought bomb.
Yes, thought bomb.
Thought bomb that you can think about this week. And then hopefully next week we'll tie everything together in a nice little pretty package so you'll know what to do with this. Again, if you want to drop us a line, please do. movingconvos@gmail.com. And until next time, keep moving, guys.
Thanks, guys.